Hello, everyone. Thank you for joining today's public webinar providing an overview of the Quality Payment Program policies in the calendar year 2023 Physician Fee Schedule Final Rule. During today's session, CMS will provide an overview of the finalized policies for the 2023 performance year of the Quality Payment Program, and they will offer resources for helping understand the final rule. This presentation will be followed by a Q&A session where attendees will have an opportunity to ask questions. You can either submit written questions via the Q&A box, or you can raise your hand to ask the question via the webinar audio. To note, CMS subject matter experts will address as many questions as time allows. A recording of this webinar and accompanying slides will be shared online on the Quality Payment Program webinar library in 1 to 2 weeks. Now I will turn it over to Dr. Michelle Schreiber at CMS to begin.
Good afternoon or good morning to those of you on the far West Coast. I'm Dr. Michelle Schreiber. I am the Deputy Director of the Center for Clinical Standards and Quality at CMS, and also the Group Director for the Quality Measurement and Value-Based Incentives Group. I'm a primary care physician by background. I'm joined today by a talented panel of CMS staff who lead the MIPS program, as well as our supporting contractors, who will share details about the QPP program, and as you heard, will take questions at the end. Before we begin, though, let me say thank you to all of you for the care that you provide and for advancing quality care for all Americans. And finally, on behalf of CMS, we wish you all a happy Thanksgiving. Today's webinar is about the Quality Payment Program, the updates for 2023 that were recently finalized in the Physician Fee Schedule. We're discussing the QPP program policies which were finalized. These policies were designed to improve quality and value, reduce burden, and increase health equity. We recognize the continued challenges faced by many clinicians across the country, as well as our patients, and we remain committed to promoting more meaningful participation for clinicians, for ensuring our policies continue to drive us towards value and improved healthcare outcomes for patients. To further these goals under the Merit-Based Incentive Payment System, or MIPS, we're continuing to focus on developing new MIPS value pathways, the MVPs, and refining the subgroup participation option for this. MVPs, as you recall, are a set of aligned quality measures, improvement activities, cost measures, and promoting interoperability, which promote quality and drive improvement for, say, a certain specialty or a clinical area, a certain population, such as improving care for diabetes, as an example. The MVPs promote alignment with our strategic objectives for the Quality Payment Program and with the CMS National Quality Strategy, as they, number one, embed quality across the care journey. Number two, they advance health equity through careful management and improvement activity selection. Number three, they foster engagement and they maximize clinical participation that is meaningful to the clinician. And finally, improve data and information sharing through enhanced comparative feedback. In the 2023 PFS rule, most of our policies focused on the development and implementation of these MIPS value pathways, which we will outline in detail during today's presentation. The goal of MVPs then is to ensure that clinicians participate in QPP in a way that makes sense for how they practice. In this final rule, we did finalize revisions to all 7 of the previously established MIPS value pathways, and we finalized 5 new MIPS value pathways, one for advancing cancer care, another for the optimal care for kidney health, optimal care for patients with episodic neurologic conditions such as epilepsy, supportive care for neurodegenerative conditions such as Parkinson's, and a new MVP for promoting wellness. We also finalized additional policies relating to MVP development and maintenance, to subgroup reporting, in other words, groups within a single large TIN or tax ID number. And we expanded the MVP inventory to embed quality into the care journey and advance health equity. Through these policies, we clarified how team-based care within MVPs can maximize clinical participation and improve data and information sharing. We also addressed policies around traditional MIPS to provide continuity and consistency. While clinicians gain familiarity with the MVPs, there are limited changes to traditional MIPS. These updates mainly focus on reporting requirements and scoring policies that will help clinicians meaningfully participate in the MIPS program. Today's subject matter experts will review the changes later in today's presentation. So in closing, thank you again for joining today's session. And I will now pass it over to Katie Moore, who is the QPP Engagement Team Lead, to give more details about today's webinar. Katie?
Great. Thank you so much, Dr. Schreiber. Really appreciate you joining us today. And welcome. Good afternoon. Good morning, everybody. Thank you all, as Michelle said, for joining us today. But more importantly, thank you so much for everything that you do every day to either as clinicians taking care of Medicare beneficiaries or the staff that supports them so that they're able to do their jobs, and then societies and all others that advocate for them. So thank you all so much for what you do every day across the country. And I see we have a large number of folks on today, so I'm really looking forward to today's discussion. So we can go ahead and get started and move forward a couple slides. And sorry about that. I saw some confusion going on in the QA about slides not moving. So we should have had just that we're on Michelle's welcoming remarks, but so don't worry, nobody missed any slides. So as we said, we are going to talk through our quality payment program policy updates that were recently released in our 2023 physician fee schedule final rule. We'll cover a lot more information on MIPS value pathways, MVPs. We're really excited to have this reporting option for 2023 and talk more about everything we have related to that. We'll go over all of our other traditional MIPS updates, as well as those related to our advanced alternative payment models. We'll touch on a couple of things related to public reporting, and then our Medicare Shared Savings Program team. We'll give you some updates there. And then we just have a couple slides on where to go for help and support. And well, I know this is a lot of information today, so as I think we've said, don't worry, the slides will be available along with transcripts and a recording of today's event. So I don't want anybody to think you have to be furiously writing down responses. So we'll have that information for you available probably in the next 2 weeks after the holidays. And we do have a number of our CMS subject matter experts, as well as our contractor support teams on the call today. So wanted to make sure you all saw the QA box. And please start, I know a lot of you have already seen that and started entering questions. So we will try and answer as many as we can throughout the presentation while other folks are talking. And then we'll get to as many as we can during the QA session live. So please keep the questions coming. And then also wanted to make sure you saw that in the chat, our team is also, as we go through the presentation and are talking about different resources and things, our team is really great about putting in some links in the chat box. So they'll direct you to a lot of the resources as we talk about them. Okay, next slide, please. So we wanted to just start off with a few reminders for end of the year. I can't believe we are almost at the end of November. So wrapping up 2022 here quickly, we wanted to make sure you knew that December 31st is our deadline for virtual group elections to be made if you want to participate as a virtual group in 2023. We also have a deadline of January 3rd for our promoting interoperability hardship exception application, as well as our MIPS extreme and uncontrollable circumstances application that will be available until January 3rd. So if you need either of those exceptions, please check out more information on our website. And then also on January 3rd, we'll be opening of data submission for our 2022 performance year. So I'm going to start saying it now because you'll hear it a few more times probably, but early data submission is always better. That way it gives you more time throughout the data submission period if you have questions, and you can call into our service center and things. So encourage folks to get your information in as soon as you can. Next slide. Okay, and just want to flag that we have a number of really great resources. I'm sure everybody on the call was ready November 2nd and reading our 1,000 pages of reg text. But if you haven't had a chance to get through the rule in its entirety, I wanted to make sure you are aware that we do have a little bit more digestible resources available on our QPP resource library. So we have a zip file that includes an overview fact sheet, really great policy comparison tables that shows you what changed from 2022 to 2023, as well as the MVP policies table and a number of frequently asked questions that hopefully is helpful for you all. Next slide, please. As we're looking towards the future of the quality payment program, we definitely are recognizing the challenges that have continued. A lot of folks across the country are continuing to face, and that we've all faced over the past few years. But wanted to make sure you all know that CMS really remains committed to promoting more meaningful participation for clinicians and ensuring that those policies aren't just developed for the sake of policies. That our goal is really to continue making policies that are necessary to help drive us towards value and an ultimate goal of always of improving health outcomes for our patients and keeping them at the center of everything that we do. So to further these goals, our policies in this final rule really focus a lot on continuing to implement new MVPs. So excited to talk more about that in a little bit, and refining that subgroup participation option. I know we've had a lot of questions from interested parties, so hopefully we'll provide some more clarity around that today. And then just some refinement that's been made to our quality measures and improvement activities inventories. And then really looking to reduce burden by facilitating participation in APM. So you'll hear more from our CMMI team in a little bit. We can go ahead to the next slide. So the next couple slides, I'll just give very high level policy updates, and then I'll turn it over to our subject matter experts to dive a little bit deeper into each of these. But As Michelle said, and you'll hear more about it soon, continuing to implement new MVPs. So we're really excited to have 5 new MVPs, and we revised our 7 previously finalized MVPs. So beginning in 2023, we will have 12 MVPs finalized and available for folks to select as a reporting option. We are also calculating and scoring administrative claims measures at the affiliated group TIN, the tax identification number level, if you're reporting it as a subgroup. And then we've also made the decision to use the initial 12-month segment of our 24-month MIPS determination period to determine eligibility for clinicians that want to participate as a subgroup. That way it gives them time to make the registration deadline. So I hope that is helpful for folks that are looking forward to participating in that way. Next slide, please. So as we are moving towards MVPs and clinicians are gaining familiarity with MVPs, we really wanted to limit the changes to traditional MIPS, just to give that continuity and consistency. So we are continuing to use the mean final score from 2017 performance year that was established for the performance threshold for 2023. So the performance threshold will remain at 75 points. We are increasing the data completeness threshold to 75% for 2024 and 2025. So for 2023, it will remain at 70% data completeness threshold. And then we've made some updates to measure reporting requirements for promoting interoperability. So you'll hear more in a little bit from Elizabeth about that. And then establishing our maximum cost improvement score of 1 percentage point for the cost performance category. So more on that in a little bit. Next slide, please. And then just a number of updates that were made to our MIPS quality measures and improvement activities inventory, expanding the definition of high priority measure to include health equity related quality measures, reduce the inventory from 200 to 198. So we've removed 11. We've also added 9 MIPS quality measures. And then we've made substantive changes to 76 of our existing MIPS quality measures, and then added 4 new improvement activities, modified 5, and removed 6. So I know that is all very high level, but if you want to dig into a little bit more on the specifics of what are the new improvement activities or what were those substantive changes, encourage folks to check out the rule, but also our resources that are available in our final rule zip file lays it out in a nice table as well. Next slide, please. And then just a couple key highlights related to alternative payment models. So we've modified how the 50 eligible clinician limit is applied to medical home models, really trying to make it easier to implement and make it more equitable. And then we've removed the 2024 expiration of the 8% minimum on the generally applicable nominal risk standard. So we've made that 8% minimum permanent going forward. So it will not expire in 2024, but definitely more to come on that. Next slide, please. Okay, I just want to also encourage folks, if we have anybody on today's webinar that is new to QPP, encourage you to sign up for our QPP listserv. That's where we send out all of our most up-to-date notifications, and we'll send out a notice when slides are available from today's event, as well as any updates to the program. So it's just a really great way to hear what's the latest with QPP. And then if you are a small practice or work with small practices, we also have a really great small practices newsletter that comes out once a month on the first Tuesday of the month. That's really tailored to small practices. So encourage you to sign up for that as well. If you go to our qpp.cms.gov website, you'll see the sign up there. So I am going to go ahead and turn it over to Sophia Sugumar, who is going to talk through our MVP final rule policies.
Great, thank you, Katie. Yes, and I'll get us started on our MIPS value pathways final rule policies. If we can move to the next slide, please. Okay, so one of the first areas we want to touch upon here is related to, you probably are aware, we in the last rulemaking cycle finalized a definition for a new term called MVP participant, which encompasses all these different submitter types here: individual clinicians, single specialty groups, multi-specialty groups, subgroups, and APM entities. We did indicate that for multi-specialty groups in the previous rule that beginning in calendar year 2026, these multi-specialty groups would have to form subgroups in order to report MVPs. And this really speaks to having more meaningful reporting and quality measures that are actually clinically directly related to the way in which a given clinician or group of clinicians practice. And so we are requiring beginning in 2026 that these multi-specialty groups break into subgroups and report in a more meaningful manner starting with that year. Next slide, please. We did want to, in this final rule, distinguish what data source we would use to determine what group, if a group is considered a single specialty group or a multi-specialty group. So we did finalize that we would be using Medicare Part B claims data to determine the specialty type. And a single specialty group would be designated as such if they only have one specialty type that is determined by the Medicare Part B claims data. And if they have more than one specialty type, they'd be deemed a multi-specialty group. And again, we would still be using the Medicare Part B claims data as the source. Next slide, please. As both Dr. Schreiber and Katie mentioned before, we have added to our inventory of MIPS value pathways. So the table on the right of the slide are our MVPs that we've previously finalized in the calendar year 2022 rule. We did propose updates to those MVPs, and that really is in alignment to updates to our quality measure and improvement activity inventories that we have within the MIPS program. And you'll note that MVP maintenance occurs on an annual basis as we make updates to MVPs, which will allow for us to then be mindful of there being new, more innovative measures and improvement activities that are put forth in our inventory. We would want to create flexibilities, including those in our MVPs. So we will continue to have this maintenance process around to make sure our MVPs reflect the latest and greatest in measures and activities. So in addition to these updates to our established MVPs, we also finalized 5 new MVPs, which reflect these various care areas, including cancer care, kidney health, episodic neurological conditions, neurodegenerative conditions, and wellness. And so that would bring our total MVP inventory to 12 MVPs for the 2023 performance year. Next slide, please. In addition to finalizing the various MVPs that we've just talked about, we've also made some modifications to our MVP development process and our maintenance process. So within our MVP development process, we finalized a process to kind of allow for more broader engagement with our interested parties, in that they would be able to provide feedback on MVP candidates that we CMS have identified as viable. We would post them on our website for a 30-day comment period, which would allow for a broader cohort of interested parties to provide feedback ahead of the rulemaking process. We would then review all the input that's received and then determine whether or not changes should be made to the MVP candidate ahead of rulemaking. I would note that we don't intend on identifying individual groups or organizations of any updates made. This will be communicated through the rulemaking process. And as you're all aware, there's a public comment period that is associated with our rulemaking process, which would allow for all interested parties to provide comments should they have any concerns with any of the updates made. Next slide, please. And in addition to the MVP development process, we also are making updates to our maintenance process as well, again, to allow for a broader cohort of interested parties to provide feedback. And with that, we are going to not only continue our process of soliciting recommendations from interested parties on previously finalized MVPs, but then also from that point, after we've reviewed the feedback, host a public webinar in which we would identify and discuss and potentially just have the opportunity for stakeholder interested parties to provide feedback on any potential future revisions we might make that we've identified through the review of all solicitations received, the recommendations received for the maintenance process. Next slide, please. With regards to the subgroups policies, we've previously finalized that the definition of a subgroup, which is a subset of a group which contains at least one MIPS eligible clinician and is identified by a combination of TINs, the subgroup identifier, and each eligible clinician's NPI. What we did propose and finalize in the calendar year 2023 rulemaking cycle was the subgroup eligibility. And this is really to help those subgroups determine whether or not they should register for MVP and subgroup reporting. We are aware that the eligibility runs occur and go until the end of December. Since MVP registration ends November 30th, we thought it would be helpful to set up this eligibility clarification or policy, which would allow subgroups to then register if they are deemed eligible by the first 12-month segment of a 24-month determination period. So if they find within that first run of eligibility that they are deemed eligible, they can register for MVP reporting and subgroup reporting. And again, you must include at least one MIPS eligible clinician as a part of your registration. If after the second run, the second 12-month segment, you find that you're no longer MIPS eligible, then you would not be able to report through MIPS, and you would not be penalized for registering and not reporting. Next slide, please. As I mentioned before, the registration period for MVP registration and subgroup registration is April 1st to November 30th. And we had previously finalized that there's several criteria that is required for a subgroup to register. We need a list of the 10 NPIs within the subgroup, a name associated with the subgroup that would be used for public reporting. We have proposed and finalized in the calendar year 2023 final rule a third element where we would ask that the subgroup then provide a description of the composition of their subgroup, which may be selected from a drop-down list or described in a narrative or a free text field. And this is really just being collected for informational purposes. We want to trend how subgroups are forming, and that will really help inform the need for future policies around subgroup formation. And so for the time being, this is informational only. There's no right or wrong answer. It's just for us to kind of track and trend over the next few years. We also finalized that a clinician would be allowed to register for one subgroup per 10, which would mean if they were only a part of one 10, they can only register for one subgroup within that 10. We did not really see the value of having a clinician a part of multiple subgroups in the same 10. And for that reason, we've finalized that policy. Next slide, please. With regards to subgroup scoring, we did finalize some changes related to the administrative claims-based measures. And these administrative claims-based measures are found within the foundational layer. They are the population health measures, which are the hospital-wide readmission measure and the multiple chronic conditions measure. There are also instances where MVPs include admin claims measures within the quality component of the MVP, which are available for selection. And also our cost measures are also admin claims based as well. What we proposed and finalized was to use the scores of these measures at the 10 level or the group level and not be scored at the subgroup level. We are aware there are instances where subgroups may be formed and they might be too small and the measures cannot be calculated. There are also some concerns with attribution of data at a subgroup level versus what they've been tested. These measures have been tested at the group level. So for the time being, we will continue to use these measures and score these measures at the group level and apply those group level scores to the subgroups. Next slide, please. As I mentioned before, if you register as a subgroup and you register for MVP reporting, and then you don't end up submitting data, you choose to, for whatever reason, decide to report traditional MIPS for another year, you would not be penalized, or if you find that you're no longer eligible through the second 12-month segment, and you will not be penalized for not submitting any data as a subgroup. So we wanted to make sure that was clear as well. Next slide, please. Okay, the next few slides, I'll get into the MIPS final rule policies. Let's go to the next slide. Thank you. And this first slide here, we talk about the 4 performance categories within MIPS generally, and that's quality, cost, improvement activities, and promoting interoperability. You'll note that each of the performance categories has an associated score percentage assigned to it, a performance category weight. And so the program is generally comprised of these 4 performance categories, and the points of each of these performance categories are then added together to give you your MIPS final score, which will then lead to a determination of whether you receive as a clinician or a group a positive, negative, or neutral payment adjustment. Next slide, please. And then this table here, you'll note that we kind of give you a comparison for the 2023 performance period. The performance category weights across traditional MIPS for individual groups and virtual groups, traditional MIPS for APM entities, and the APP, so individuals, groups, and APM entities that report the APP. We are, as a reminder, statutorily required to have cost and quality weighted equally, beginning with the 2022 performance year. So this has been ongoing since this year. We will also note that the APP has different scoring weights compared to the APM entities who participate in traditional MIPS, that middle column there. When an APM entity reports traditional MIPS, we reweight the quality performance category to 55% according to the traditional MIPS performance category reweighting rules, as opposed to the APP where it's at 50%. Next slide, please. With regards to our policies around third-party intermediaries, we have finalized for the qualified clinical data registries and their measure testing requirements. We have finalized a delay in the requirement for full measure testing, and we have delayed that until calendar year 2024. We aren't changing requirements that QCDR measures be fully tested prior to their inclusion into an MIPS value pathway. So as we've expected in this past go around of MVP implementation, any MVP that includes QCDR measures will only do so if those measures have been fully tested at the clinician level. So we do check that. And if any instance they are not fully tested, we would not be able to finalize those measures within an MVP through the rule. In addition to that requirement for QCDR measure specifications, we have updated the current language or current policies to provide QCDRs with a clear timeline of when they should be posting their QCDR measure specifications, such that 15 calendar days after we post the approved QCDR measure specifications, the entity must publicly post their specifications, confirm measure specifications that they post with the measure specifications posted by CMS, and provide a link to where that information is posted. We have previously in the past seen differences in what we've approved versus what the QCDRs have posted, and we want to make sure that does not occur. We don't want clinicians getting confused as to what the measures are required or the expectations of the measure and what is posted on the CMS website. And QCDR should make sure that they, QA what they have posted on their website, and it reflects what we have approved from the CMS side. So we want to make that abundantly clear through that policy. Next slide, please. With regards to remedial action and termination, we have broadened the scope of affected parties under the corrective action plan. Typically, corrective action plans are applied to third-party intermediaries when we've seen there has been negative impacts to clinicians, but we also are aware when it comes to QCDRs, there might be some instances where negative actions also affect other QCDRs. And I think we want to be mindful of that, of those negative impacts, and we want to make sure our corrective action policies reflect that, which is why we've made that, we've updated our policies to reflect that, actions that also impact other QCDRs may also be taken into consideration when we put someone on put a QCDR on a corrective action plan. We also added a new corrective action plan requirement for TPIs to develop a communication plan for communicating the impact to the parties identified in the second corrective action plan requirement. In addition to this item, we also finalized the termination of approved QCDRs or registries that have continued to not submit performance data to us year over year. So beginning with the calendar year 2024, we will terminate those QCDRs or registries that are required to submit a participation plan under the existing policy. and they've submitted one and we've approved it, but we have not seen any changes. We have not seen any uptick in data submitted to us. We have had third-party intermediaries be approved year over year and not submit data to us. We are well aware they do that, so they have that designation of CMS approved, but are not really seeing any movement there from them from a data standpoint. So if we're not seeing that change after the participation plan, we would then terminate their approval, and they would not participate in the MIPS program as a QCDR or a registry. Next slide, please. All right, so with this, I will turn it over to my colleague, Lisa Marie Gomez, for quality. Thank you.
Great, thanks, Sophia. Next slide, please. So I will be discussing the policies that we established for 2023 with regard to the quality performance category. So as previously indicated during the introductory slides, we highlighted that we have reduced the measure inventory from 200 measures to 198 measures for the 2023 performance year. So on an annual basis, we review all of our measures to see if there are any measures that are topped out, any particular area like priority areas in which we want new measures to be established for our program. So as a result of that annual review, we added 9 MIPS quality measures, which includes 1 administrative claims measure, 1 composite measure, 5 high priority measures, and 2 new patient reported outcome measures. We also made substantive changes to 76 existing MIPS quality measures. I also want to note that we added and removed measures with regard to specialty sets. We also removed 11 MIPS quality measures and partially removed 2 MIPS quality measures, in which 2 measures were removed from traditional MIPS, and those same 2 were retained for MVP use. I just want to note that QCR measures are included in the above measure inventory. So again, for 2023, we have a total of 198 measures that are available for selection to report. Next slide, please. Now I'm going to discuss benchmarks for administrative claims measures. So in the 2023 PFS final rule, we determined that we would exclusively use performance period benchmarks for scoring administrative claims-based quality measures. So this is a different dynamic than we've had previously with regard to establishing benchmarks. So again, for 2020, or starting with 2023, we will be using performance period benchmarks for scoring administrative claims-based quality measures. Next slide, please. Now I'm going to discuss data completeness. So I just want to preface the conversation that when we established the data completeness thresholds, we did them in advance of the applicable performance year. So for the 2023 performance period, we established a data completeness threshold of 70%, and that was established in the 2022 PFS final rule. In the 2023 PFS final rule, we established a data completeness threshold with an increase to 75%. And that increase is specific to the 2024 and 2025 performance periods. So our goal is to give advance notice so that groups, virtual groups, individual clinicians, APM entities participating in MIPS are aware of what our data completeness thresholds are with regard to performance periods that are several years in advance. So again, for 2023 performance period, the data completeness threshold is set at 70%, which has been that same threshold for the last 3 previous performance periods. And starting with 2024 and for 2025 performance periods, the data completeness threshold is at 75%. So there is an increase that will start in 2024. Next slide, please. Now I'm going to discuss high priority measure. So in the PFS final rule, 2023 PFS final rule, we extended the definition of a high priority measure. And with that expansion, we included health equity related quality measures. So here on this slide, it highlights all of the elements and types of measures that we consider to be a high priority measure. Next slide, please. The last item I'm going to discuss with regard to quality performance category policy updates is in relation to the CAPS for MIPS survey. So for the CAPS for MIPS survey, the case mix adjustment model includes the following case mix adjusters. And for the last item listed for case mix adjusters, we modified the Asian language survey completion, and we removed that specific case mix adjuster and replaced it with Spanish language spoken at home, Asian language spoken at home, and other language spoken at home. So it's just expanding the types of language that are spoken at home and those who are completing the survey. So that's what we've done for the CAPS for MIPS survey. Next slide, please. Now I'm going to turn it over to my colleague, Ray, who will discuss cost performance category policies.
Thanks, Lisa Marie, and hi, everyone. My name is Ray Desatel, and I will quickly go over the cost category slide. So for cost, CMS is establishing a maximum cost improvement score of 1 percentage point out of 100 percentage points available. And just to note, all MIPS eligible clinicians will receive a cost improvement score of 0 percentage points for the 2022 performance period because CMS did not calculate cost measure scores for the 2021 performance period. And we are establishing this policy to meet the statutory requirements of accounting for improvement in the assessment of cost performance. And that's all I have for cost. I'll now pass it over to Michelle Peterman for improvement activities.
Thank you, Ray. My name is Michelle Peterman, and I will be reviewing the traditional MIPS improvement activities or IA policies that we have finalized for calendar year 2023. Our policies this rulemaking year were focused primarily on the IA inventory, which consists of 104 IAs for calendar year 2023. We finalized adding 4 new, modifying 5, and removing 6 IAs as proposed, with the exception of the COVID-19 vaccine promotion for practice staff, which we finalized with a minor change. For the new IAs, we finalized 3 IAs as proposed, 2 of those in the Achieving Health Equity subcategory, including the use of security labeling services available in certified health IT for EHR data to facilitate data segmentation, and creating and implementing a plan to improve care for lesbian, gay, bisexual, transgender, and queer patients. In the expanded practice access subcategory, we finalized create and implement a language access plan, and all of those were as proposed. The 1 IA that we finalized with a minor change from what was proposed was in the emergency response and preparedness subcategory. That one's titled COVID-19 vaccine promotion for practice staff. Through the comments we received, we recognize that there may be instances when there's a contraindication for COVID-19 vaccine. Therefore, we included language that allows for exceptions for practice staff who have a contraindication in accordance with the Center for Disease Control and Prevention to be excluded from this activity. We also finalized all of the proposed modifications and removals as proposed. For the modifications, we finalized to rename and refocus CC14, which was titled Practice Improvements that Engage Community Resources to Support Patient Health Goals, and it was categorized in the Care Coordination subcategory. The modifications we finalized were to move this IA to the Achieving Health Equity subcategory, and we renamed it Practice Improvements that Engage Community Resources to Address Drivers of Health. We believe that the Achieving Health Equity subcategory more appropriately reflects this IA's intent, and the updated terminology drivers of health better encompasses both social determinants of health and health-related social need concepts. We also finalized and updated a list of activities that may be used to address identified drivers of health. Second, we finalized to revise CC13. It was titled Practice Improvements for Bilateral Exchange of Patient Information. We finalized to change this title to Practice Improvements to align with Open Notes Principles, and we're explicitly requiring engagement in open notes for this one. For the removals, we removed PSPA 30. That was the PCI bleeding campaign. This campaign concluded in August 31, 2021. Therefore, that's why it was removed. We also removed PSPA 6. That one was the Consultation of Prescription Drug Monitoring Program. We're removing this one because it is duplicative of the PI measure, which is being finalized in this rule to be required, the query of PDMP measures for MIPS eligible clinicians, and that one is PIEP2. The other finalized IA removals are pretty much being consolidated into other IAs, so they're technically still available for completion and attestation. If you'd like to review these proposals in more detail, they are available in the Appendix 2, Tables A, B, and C of the final rule. In January, the updates to the IA inventory may be reviewed on the QPP website Measures and Activities Lookup tool. This concludes the IA policies for 2023. I will now pass the presentation over to Elizabeth Holland.
Thank you, Michelle. Before we jump into promoting interoperability, just as a reminder, as we finalized in the CY 2021 PFS final rule, that was back in December of 2020. We finalized that the 2015 edition Cures update version of certified EHR technology would be required for performance periods in 2023. Next slide, please. Okay, so we decided not to continue the automatic reweighting for certain clinician types. So that would be nurse practitioners, physician assistants, certified registered nurse anesthetist, and clinical nurse social specialists. So these types now will be required to submit promoting interoperability measures. We are continuing the automatic reweighting for the following clinician types in 2023: clinical social workers, physical therapists, occupational therapists, qualified speech language pathologists, qualified audiologists, clinical psychologists, and registered dietitians or nutrition professionals. And just as a reminder, if you are a small practice, you will be automatically reweighted for promoting interoperability. But if you choose to submit data, that data will be scored. So our policy that we established last year is still in place, that small practices do not need to submit a hardship exception. Next slide, please. Okay, when participating in MIPS at the APM level, CMS will allow APM entities to report their promoting interoperability performance category data at the APM entity level. They still have the option to report at the individual or group level. Next slide, please. Okay, so we made some changes to the public health and clinical data exchange objective. So first, for the levels of engagement, we currently have 3 levels of engagement, and we collapsed them into 2. So the first 2 options are combined into one option called pre-production and validation. And the third option, which used to be called just production, is now called validated data production. So now there are 2 options. We're also requiring that MIPS eligible clinicians submit their level of engagement for each measure. So the immunization registry measure and the electronic case reporting measures are required. So at a minimum, when you submit those measures, you have to submit your level of active engagement, either option 1 or option 2. And if you submit one of the optional public health measures, you will also be required to submit your level of engagement for that. Then we're also instituting time constraints so that clinicians move forward through the process. We believe it's really important to have everybody be at the validated data production. We work very closely with the Centers for Disease Control and Prevention, and having this data is really important, especially when we're fighting various pandemics. So we are setting the time constraints that you can only spend 1 performance period at the option 1, the pre-production and validation level, and then you must move on in the next performance period to the validated data production. And this policy is not into effect till 2024, so you could still be in pre-production and validation for 2022, you could be in it for 2023, and then in 2024, you could still be at it, but by 2025, you need to be at the validated data production. The one exception to this, if you choose to report to a different registry, if like you were reporting to a local immunization registry and decided to submit to a national one, you would start over and you would get an additional year at pre-production and validation. Next slide, please. So as Michelle mentioned, we are making the query of prescription drug monitoring program, or PDP measure, required. It has been an optional measure for several years, and we're making it required. With it being made required, we're adding exclusions for the measure, and it will be worth 10 points, which is just what it was worth as a bonus measure. We also expanded the scope of the measure to include not only the Schedule II opioids as it is now, but also to include Schedules 3 and 4 drugs. Next slide, please. And we have another option for health information exchange. Currently, you can report the 2 support electronic referral loops measure, or you can report the health information exchange by directional exchange measure. We're adding a new measure, enabling exchange under the Trusted Exchange Framework and Common Agreement, or TEFCA. Just like the bidirectional exchange measure, this is also a yes/no measure. Next slide, please. So with all these changes and making the query of PDP required, and also realizing how important the reporting of public health and clinical data exchange measures are, we reconfigured the points allocations for all the measures. So we moved some points from health information exchange to accommodate the query of PDP measure. And we also reallocated the points from provide patients electronic access to their health information to the public health and clinical data exchange. Next slide, please. And I am now turning it over to Zenobia Raspberry to discuss final rule policies.
Thanks, Elizabeth. This year in the final rule, we finalized proposals related to facility-based measurement and our performance threshold. The first of which I'm going to discuss is our policy that discusses the interaction between the complex patient bonus and facility-based measurement. Those 2 policies were established in the same year, and previously discussion didn't include how those 2 policies interacted. So this year we finalized a proposal to allow facility-based clinicians to receive the complex patient bonus. As an additional note, there is no data submission requirement for these facility-based clinicians to be able to be scored for the complex patient bonus if that bonus can be applied. This is consistent with our facility-based measurement policy that does not require data submission for individual clinicians, even though the complex patient bonus does require submission for at least one MIPS category. Moving on to the next policy. Can you go back to the last slide, please? Thanks. We are allowing virtual groups to be scored for facility-based measurement as well, as long as those groups meet the criteria for facility-based eligibility. Previously, facility-based policy did not discuss or inadvertently omitted virtual groups. And as an additional note, these virtual groups would be scored under facility-based measurement, even if they do not submit data. This is consistent with our policy on virtual groups that states that registering as a virtual group signals intent to participate and be scored as a virtual group. Next slide, please. Now to discuss our performance threshold policies. As a reminder, beginning in the 2022 performance year, we were statutorily mandated to set our performance threshold at either the mean or median of prior year's performance. we opted to use the mean final score from the 2017 performance year, which was 75 points. In the 23 final rule, we finalized a policy to continue to use this mean final score from 2017 and set the performance threshold at 75 points. As an additional note, calendar year 2022 was the last year that the additional performance threshold would be applied for exceptional performance. Next slide, please. And so here on this chart, we can see the breakdown between the points and the corresponding payment adjustments and their corresponding percentage value. So as a note on the right side for the 2023 final rule, neutral payments will be set at 75 points. And I would also like to highlight again that in this right column, there is no exceptional performance threshold. So 2022 was the final year for that 89 points exceptional performance adjustment. Next slide, please. And now I'll pass it over to Richard Jensen to discuss the APM policies.
Thank you, Zenobia. Next slide, please. So as was mentioned earlier, we are revising our medical home model 50 clinician limit. The limit has been in place since the inception of the program. It has been used as a way to ensure that only appropriately sized entities are using the medical home model option. But we have found over time that there have been some issues with implementation and a concern about whether similar entities were being treated in an equitable manner. And so we've made a revision this year. CMS will identify the clinicians in the APM entity by using the TIN NPIs on the participation list of the APM entity on each of the 3 QP determinations dates. Those are March 31st, June 30th, and August 31st. And this policy will become effective in the 2023 performance year. In addition, we under current regulations, our 8% minimum generally applicable nominal risk standard for advanced APM was going to expire. And so we removed the expiration, and the 8% minimum permanent standard will be in place into perpetuity. And next, I'm going to hand it off to Julie Johnson to talk about public reporting.
Thanks, Richard. We have finalized 2 significant policy updates for public reporting on the doctors and clinicians section of Medicare Care Compare for 2023. First, we have finalized the public reporting of commonly performed procedures on individual clinician profile pages. Adding this data or utilization data will aid patients in finding clinicians who may appropriately serve their needs and who have performed specific types of procedures. Second, we have also finalized adding a telehealth indicator as applicable and technically feasible on individual clinician profile pages for those clinicians furnishing covered telehealth services. Adding telehealth indicators to profile pages help to empower patients' healthcare decisions and increases access to healthcare information about options available to them. That concludes the updates for public reporting, and I'm now turning it over to the Medicare Shared Savings Program.
Thanks, Julie. This is Sabrina Ahmed. I'll be reviewing some of the major changes to the Shared Savings Program that we finalized in the 2023 PFS Final Rule. There is also a CMS fact sheet available that summarizes the policies finalized for the Shared Savings Program, and you can locate the fact sheet in the Program Statutes and Regulations section of the Shared Savings Program website. So we finalized the proposed changes to the quality performance standard requirements under the Shared Savings Program. These final policies are designed to support the transition of the ACOs to the required reporting of ECQMs and MIPS CQMs beginning in performance year 2025 after the sunsetting of the CMS web interface measure set. So beginning with performance year 2023, we finalized our proposal to reinstate a modified sliding scale approach for determining shared savings for all ACOs, regardless of how they report their quality data to CMS. So this policy would allow flexibility for ACOs that fall below the current level of performance required to receive the maximum sharing rate for their track and avoid the all or nothing approach to shared savings. Next slide, please. For performance year 2023 and subsequent performance years, we also finalized our proposal to implement a health equity adjustment of up to 10 bonus points to an ACO's MIPS quality performance category score when the ACO reports the 3 all-pair ECQMs or MIPS CQMs and based on high quality measure performance and providing care for a higher proportion of underserved or dually eligible beneficiaries. This policy would only affect ACOs positively and would not penalize them. Additionally, we finalized our proposal to extend the incentive for reporting ECQMs or MIPS CQMs through performance year 2024. Next slide, please. This slide highlights a number of other quality-related policies that we finalized. We clarified the use of unweighted MIPS quality performance category scores for quality performance standard determination under the shared savings program. We clarified that we will reopen an ACO's initial determination to correct errors in the MIPS quality performance category score identified through the MIPS targeted review process. Lastly, for the web interface measures, we finalized our proposals to establish benchmarks for performance years 2022, 23, and 24, and to score using flat percentage benchmarks, the depression screening and smoking cessation measures for performance year 2023 and subsequent performance years. So this concludes the highlights of the final policies related to the shared savings program. Next, I would like to turn it over to Katie Moore.
Awesome. Thanks, Sabrina. And thank you to all of our SMEs today as well. Just real quick, one more slide, we can move forward. We're almost at the end. So thank you everybody for hanging in there with us. We should have a good bit of time for questions. So again, just flagging our final rule resources, our QPP final rule resources available. So check out that zip file as well as a link on cms.gov to where you can get to the final rule on the Federal Register. Next slide. And then before we get to the QA, also just want to remind folks that we always have our wonderful service center agents available to ask questions and help get you the information you need to participate in QPP. So encourage you to give them a call if you have any additional questions. But we will try to get to as many as we can today. And thank you again so much. And with that, I'm going to turn it over to Olivia, who's going to walk us through how the QA session is going to go.
Great, thank you, Katie. And yes, we are now going to start the Q&A portion of today's webinar. So just a quick reminder, you can ask questions using the Q&A box, and we have seen quite a few. So thank you for those who have submitted questions. But you can also raise your hand, and that will allow you to ask a question via webinar audio. So when we start to take questions via the phone lines, we will read your name out and unmute your line. Just a reminder, you may have to unmute on your end as well. Perfect. So I think we can get started with a couple of questions that we have seen come through the Q&A box. And Ray, we did get a few requests just to clarify the cost information. So if we can go back to slide 33, please. And Ray, do you mind just providing another high-level overview? Just specifically, we got quite a few questions on if it will be the cost performance category will be automatically re-weighted to 0 for 2022.
Yeah, thanks, Olivia. So the cost performance category will be 30% for 2022. So this slide is going over accounting for cost improvement scoring. So we're establishing a maximum cost improvement score of 1 percentage point out of 100 percentage points available. And MIPS eligible clinicians will receive a cost improvement score of 0 percentage points for 2022 performance period because we did not calculate cost measure scores in 2021 performance period. And that's because we have to have 2 consecutive performance periods to measure improvement on. And again, we're establishing this cost improvement policy to meet the statutory requirements of accounting for improvement in the assessment of cost.
Thank you, Ray. And we can go back to that Q&A slide, please. And Elizabeth, we did see quite a few questions, and I know you've been answering some just about the cures update. So not sure if you can give a quick overview on when the updates need to be completed and when it needs to be certified.
Okay, for the promoting interoperability performance category, you need the functionality in place by the first day of your performance period. And you need it certified by the last day of your performance period. So if you choose, I guess it's like October 3rd or something like that, the very last time in 2023, when you can start your 90-day period, it would need to be certified by December 31st. For ECQMs, my understanding is there are not changes to the requirements for ECQM. So if you're running, you don't need it in place by January 1st. You need it in place when you're generating the data, because the data will be generated from the entire year. And so as long as it's the data for submission is generated using the 2015 Cures update, you can submit that data for the 2023 performance period for ECQMs.
Great, thank you. And then Sophia, we're just going to turn to you. We got quite a few questions on MVPs, so we'll start with the first one. For MVPs that were only finalized with the most recent 2023 final rule, is it still accurate that third-party intermediaries, qualified registries, health IT vendors must support all measures and activities within the relevant MVP?
Yes, so you must support all. I think the question we get a lot is more so, do I have to support all the measures in the MVP? You have to support all the measures, but if the measure is specified in multiple collection types, for example, if a measure is available as a CQM or ECQ and an ECQM, we haven't specified that you have to support all collection types in which the measure is available. So if you only support CQM measures, then you would support the CQM version of that given measure. But the expectation is generally that you as the third-party intermediary can support the submission of data for all the measures within the MVP that you've chosen to support and list on your qualified posting.
Great, thank you. And then another question, if my group has registered by June 30th for an MVP that includes caps, can we choose a different MVP with or without caps before November 30th and to the registration period?
Yes, you'd have to make an update to your registration to indicate the change. Obviously, if you are if you're picking another MVP that includes caps, then you wouldn't have to re-register for caps. Because that's already been tracked to in a separate process. But if you're picking an MVP that no longer has caps, I think we would just want to track to that. So it would be good that for you to go and make that change ahead of the close of registration. After November 30th, you would not be allowed to make any changes to the MVP you've registered to.
Okay, and then another MVP question, will practices who are eligible to submit MVPs also be required to submit MIPS?
And technically MVPs are MIPS, but thinking of them as two different tracks, we have traditional MIPS and then we have MVPs. You are not expected to report both. However, we are aware there might be, clinicians and groups that may want to try to submit both to see, where they do better. And we do have a scoring hierarchy that allows for clinicians or MVP participants to submit an MVP and then separately submit data for traditional MIPS. And we would calculate each of those separately, your MVP score, and then we would look at your traditional MIPS score, and the higher of the two would count as your final MIPS score. So it's all MIPS. We give some flexibility. You are not in any way mandated to report both traditional MIPS and MVPs, but you can if that's what you choose to do.
Great. And then we did get a request just to explain what a subgroup identifier is.
Sure. So a subgroup identifier is something we CMS will assign to a subgroup. That is only after the subgroup registration process is complete. It's a unique identifier that help us identify your let's say your 10 forms 5 subgroups. Each one of those subgroups would have a unique subgroup identifier, which would just help us kind of track that data submission. So we would understand that this subgroup is identified, the subgroup identifier 1, 2, 3, 4, 5, and they are submitting on MVP 1 versus another subgroup within your TIM is submitting a different MVP. It'll just help us distinguish one from the other, and then also trace back your subgroup to your parent TIN. So we will be assigning those after you've successfully registered as the subgroup. You will receive a notification from us with your subgroup identifier. And I'll just say there's more to come with regards to guidance on MVP registration and subgroup registration. I know we got a lot of subgroup registration questions that came in, but there's additional guidance that we are developing that will come forward soon that will help facilitate that process.
Great. And then do you mind just clarifying, someone asked if they can have multiple subgroups under one TIN?
Sure. Yes, you can. So if you're a TIN can have multiple subgroups within their TIN. So you can, for example, if a group decides to have five unique subgroups, that's completely fine. The thing that we've finalized in terms of policy is we would only allow a given clinician a part of that TIN can only be a part of one subgroup within that TIN. So if that clinician is a part of multiple TINs, there's nothing to say that they can't be a part of multiple subgroups, but only one subgroup per TIN, if that makes sense.
Yes. And then one other question, can multi-specialty groups have some of their eligible clinicians register as a subgroup and others report traditional MIPS?
Yes. So we would, that flexibility is there. So if you have an MVP that's pertinent to, let's say, your oncologist in your group, and then they want to report the cancer care MVP, and others that are not of the oncology specialty would like to continue to report traditional MIPS, your oncologist can form a subgroup, register, report the oncology MVP because that's clinically relevant to them. And the others, if they don't have an MVP available to them yet, or they're not yet ready to report MVPs when it's still voluntary, they can continue to report traditional MIPS.
Great. We did get a couple, excuse me, of requests just to explain how the 70% data completeness requirement is measured and verified.
I think that's related to quality, Olivia, is that right?
Yeah, hi, this is Lisa Marie. Thank you. Can you repeat the question? So I heard that it's a question with regard to data completeness and how it's verified. Is that correct?
Yes, it reads, how is the 70% data completeness requirement measured and verified?
So with regard to that question, I will note that when folks sign into the quality payment program and are in the process of submitting measures, we have included a statement of truth that outlines, how and when individuals submit data, that it's complete and accurate. So that's like one way in which that we verify that information that has been provided to us as accurate and complete is by every clinician or group submitting data attest to reporting data that's accurate. We also have an audit process that looks at data that is submitted. So each clinician or actually any practice that is participating in MIPS, they are required to retain records and data for at least, I think it's like five years to be able to replicate data in terms of how they extract data. When we conduct our auditing process, we're able to verify exactly how the data that was retrieved and verify that that information is meeting all of the requirements, not just data completeness, but all of our reporting requirements. So right now, that's the way in which we currently assess and make determinations in terms of practices meeting our reporting requirements and the quality payment program specific to quality performance category.
Thank you, Lisa Marie. And Michelle, we do have a question for you. It reads, do the improvement activities still have a minimum of 50% participation by eligible clinicians?
Yes, so several years ago, we passed a policy that if a clinician is part of a group, that 50% of the group must perform the same improvement activity for 90 days in the same performance year. They don't have to do it at the same time during the entire year, but they must do it during the performance year. So one part of the group could do it, in January, another part could do it in June, whatever fits the practice's desire, but 50% of the group must perform the activity. So yes.
Great. I think we can switch over to a couple of the phone line questions. So just a reminder for folks, if you do want to ask a question live, you just have to raise your hand and we will call on you. So we'll start with the first person who has their hand raised, Rosalind Lowry. We will unmute your line and you can ask your question.
Yeah, hi, can you guys hear me?
Yes.
Hi, thank you so much. Just have a quick question, and you guys might not have an answer for it. Has there been any consideration given to the fact that most third-party like EMR vendors aren't able to, or rather don't release updated specifications for their measures until like June or July at the earliest? So for example, I'm a consultant. One client, I just got an email today that their EMR released their final specifications for 2022. It just makes it extremely difficult for practices to meet the 70% data completeness and to get an accurate estimate on how they're going to perform.
Is anyone able to answer that question? Otherwise, we can plan to connect with Rosalind offline.
Would she be able to repeat the question?
Yeah, have you guys considered at all with the data completeness being 70 and then 75% next year, that most EMR vendors don't implement updated specifications for their quality measures for their ECQMs until June or July at the earliest, and some EMRs even go later into like November, like today. It just makes it extremely difficult for the practices to meet the data completeness. My client, for example, who just got the update today that their measures were updated, went from an 85% for one measure to a 0 because the SNOMED code that they were utilizing got removed, but they weren't notified until today. And just, it makes it difficult. And with the implementation of the MVPs, I didn't see anything that said when the EMRs or the third-party vendors had to be able to support them. So I just want to make sure that my clients have time to register for an quality measures, especially with all of the changes that were made. I'm assuming a lot of measures aren't going to have benchmarks. Just trying to figure out how to navigate the quality category.
No, I think actually, thank you. Your feedback is helpful. So as we develop, so data completeness threshold has been in existence since the inception of the quality payment program. And so as we have increased the data completeness, so early on in the quality payment program, we increased the data completeness actually every year. Due to the public health emergency, we have kept it stabilized at 70%. I recognize that you have indicated that there may be issues in which, let's say, certain codes change and the EHRs aren't able to quickly address those dynamics. But what I will note is that, and as we indicate in the 2023 PFS final rule, that when we do increase the data completeness threshold, we do want to give adequate time in which vendors, practices, whether they're to practice individual solo practitioners or groups, virtual groups, or even like APM entities, we want to give adequate notice so that they do have time to prepare for the increase in data completeness. It's also our understanding in terms of data completeness, whether it's 70% or 75%, or even if it's a 60%, any data completeness threshold, that amount shouldn't necessarily impact the architecture of and create excess burden when there is a data incompleteness threshold. So during the comment period, the information that you're indicating now, we didn't receive that type of feedback during the comment period. But if, as we do increase data completeness thresholds, it is helpful for us to continue to receive feedback, whether it's from the perspective of vendors or even the perspective of, let's say, as you're indicating, you're trying to prepare your clinicians to participate in MVP. Any feedback is helpful that we can take into consideration as we do implement new policies, whether it's data completeness threshold increase or even other policies. But it is helpful for us to know, because if we don't receive that feedback, we're unable to know, we don't know that information. So the specific information that you're indicating, like specific about, let's say like SNOMED codes being removed, how that impacts data completeness. We can take a look at that to see.
It's not so much
really
data completeness in that example. It's that, by the time the updated specifications are being implemented, it's July, and most practices have seen over 50% of their patients. So if they go through January through July documenting a certain way, and then things change, they have to go back to be able to hit that 70% and update codes, update documentation. And that's just an administrative burden that's a bit excessive in some cases. Sorry, I know that I'm taking up a lot of time. I want to give other people time to answer questions.
Thank you for your
Yeah,
feedback.
Just to jump in here, Rosin, we can connect you with the right contact offline, knowing that we're coming up on running out of some time.
Yeah, sorry.
Okay, and we're just going to turn back to the Q&A box. We do have a couple of other questions. So the next question reads, would you mind explaining the Medicare Shared Savings Program bonus points for ECQM submission a bit more? How many points could be achieved and how?
Hi, sure. So we assume you're referring to the health equity adjustment bonus points, and the health equity adjustment would upwardly adjust quality performance scores for ACOs that serve a high proportion of underserved individuals and achieve high quality performance. So the adjustments available for PY 2023 and subsequent years to ACOs that report the 3 ECQMs, MIPS CQMs in the APP measure set, meeting the data completeness requirement and administering the CAPS for MIPS survey. So these ACOs may receive up to a maximum of 10 additional points added to their MIPS quality performance category score. The points up to 10 are awarded based on a measure performance scalar and an underserved multiplier. So the underserved multiplier will be determined based on the higher of either the proportion of the ACO's assigned beneficiaries residing in a census block group with an ADI national percentile rank of at least 85, or the proportion of the ACO's assigned beneficiaries that are enrolled in LIS or are duly eligible for Medicare and Medicaid. And then the scalar, the measure performance scalar, That considers the ACO's performance on all measures in the APP measure set. And we create 3 groups based on measure performance, so a top, middle, and bottom third of performing ACOs. And these groups would be created for each of the 6 measures independently. So an ACO can be in the top group based on one measure performance, maybe in the bottom based on another measure performance. But we assign a value for each measure based on where its performance places it in the top, middle, or bottom third. And then these values get added up, and that total is the measure performance scalar. So this scalar is combined again with the underserved population to get the total points that you'll receive. But it's examples of this calculation are also outlined in the 2023 PFS if you want more information.
Great, thank you, Lauren. And I think we have time for one more question. So Sophia, just one final question for you. As a multi-specialty registry, do we need to select all the MVPs for the 7 old and 5 new in the self-nomination form for reporting?
We have not mandated that in this sense, you were talking about QCDRs and registries. We have not mandated that they are required to support all MVPs that are available. You should support MVPs to the extent that it is operationally feasible. You should be supporting MVPs that are clinically relevant to the specialties you support. And so we don't make assumptions that just because you support multiple specialties that you can support all MVPs. We would rely on the third-party intermediaries to make those decisions. Inevitably, there will be a time in the future, as we've signaled in years past, that we will transition completely to MIPS value pathways and sunset traditional MIPS. That timing is to be determined, but in any case, preparing for a future state where you only support MIPS value pathways and might have to support several is something that our third-party intermediaries should start thinking through. Thank you.
Thank you. And it looks like we are just about at time. So we're going to conclude the Q&A portion of this webinar. And Katie, I will turn it back over to you to close us out.
Great. Thanks, Olivia. And thank you, everybody, so much for joining today. Again, reminder slides and everything will be available in the webinar library in the next 2 weeks. And we look forward to talking with you all next time. Have a great rest of the day. Happy Thanksgiving.